So this is a little bit different of a session. Instead of everyone speaking to you or at you, we are inviting you all to participate in this session. So what we're going to do first is the Denver Clinic team is going to introduce themselves. Oh, sorry. Let me follow the camera. Sorry. The Zoom people hate me already. Okay. And the Denver team is going to introduce themselves. They have a mic up top, a mic down here. They're going to go down the line, introduce themselves, say what they do at the CMTA Center of Excellence here in Denver. And then we are going to open it up for questions from you all. What do you want to know? What are your burning questions? If it is, here's my only caveat. If it is a PTOT question, I would ask that you please hold it for the next session. Because right after this, we will go into PTOT session, and then we will go into bracing. So we're going to hold the PTOT and bracing questions. But if you have questions as it relates to CMT, the diagnostic journey, the patient experience in the clinic, genetic testing, do nerve conduction tests hurt or not? You know, those kind of burning questions. Feel free to ask them. So we'll start with introductions, and then we'll look for hands to go up around the room. So thank you all for being here.
Hi. Whoa. I'm Vera Fridman. I am a neuromuscular clinician with clinical and research focus on hereditary neuropathy. And I run the CMTA Center of Excellence on the adult side here at the University of Colorado, and many of you I've seen. And it's such a pleasure to be here. And I just want to say one quick sort of preliminary enormous thank you to the CMTA for having all of us here. It means a lot to me. I actually was at an event like this 9 years ago in Boston because I started my career in Boston. And it means just a great deal to be here in Denver doing this again.
I'm Michele Yang. I'm Vera's counterpart over the children's side. So I'm the pediatric neurologist with subspecialty training in neuromuscular disease. I do EMGs and nerve conduction studies in kids, so feel free to ask me any questions about that. We try to steer away from doing that very often, but we occasionally do it. But I'm going to introduce you to the rest of my big team.
Hi, I'm Margaret Siobhan Murphy-Zane. I'm a pediatric orthopedic surgeon at Children's Hospital, Colorado. Also started my career in Boston. Privileged to be surrounded on my team by some of the smartest gals I know. So
I'll agree with that. Some of the most wonderful people I know. I'm Caitlin Silver. I'm an occupational therapist. I'm part of the CMT Clinic at Children's Colorado.
Hello, I'm Carolyn Kelly. I'm a physical therapist, also at Children's Hospital, Colorado. And we also have two other PTs, great PTs on our team, Megan and Sarah, who are in the back.
My name is Robert Will. I'm a physical therapist on the adult side with Dr. Fridman. And thanks for having us here today.
Karen Hookstead, occupational therapist at University Hospital for Adults.
I'm Allison Wheeler. I'm a genetic counselor. I had the incredible opportunity to do a fellowship this past year with both the adult teams and the Peds teams to learn not only from the genetics side of neurology and neuromuscular disorders, but everybody else on both teams to see what the full experience of living with CMT is. So learning not just about PT and OT and surgical outcomes, but also learning from families and patients throughout the lifespan.
Hi, my name is Marissa Lafreniere. I am a genetic counselor on the adult side, working with Dr. Fridman. I also got to be trained by this one. So I did a fellowship as well of both peds and adult neuromuscular disorders.
I'm Melissa Gibbons. I'm also a genetic counselor, and I am on the pediatric side.
I'm Kelly Browning. I'm the nurse practitioner in the neuromuscular clinic at Children's Hospital, Colorado, with a focus in rehabilitation medicine.
And I'm Hattie Foster. I am the clinical nurse coordinator for the CMT and neuromuscular clinics at Children's Hospital, Colorado. And I am frequently the first point of contact for anyone who has a child who they want to have evaluated for CMT or to establish in our clinic if they have a known diagnosis of CMT.
Thank you, everyone. We now have 60 CMTA Centers of Excellence in the country and around the world. This team right here is one of the most comprehensive brilliant, and kind clinic that you will meet. So we're so grateful to have you all here today. Okay, here's the crazy part of it. We're opening it up to Q&A. So I'm going to run around at the speed of heat to your raised hand. So who would like to go first? If you go first, yes, you get an ice cream this afternoon. Okay.
I already got the ice cream ticket. So I'd like to indulge in supplements, natural supplements, and was wondering if any of you guys have found any that are beneficial to our cause. I have found, I think, that essential amino acids has been helpful for me, as well as taking creatine. But was curious if you guys had any input.
All right. I guess I'll take that one. Hi. So this is a whole area of science. What I tell my patients in clinic is that as of today, we have limited, confirmed, validated clinical data to support that supplements change the outcome in CMT. There's some evidence for alpha-lipoic acid in certain types of neuropathy, but it is not, there's no cocktail of supplements that we've identified to slow progression or change pain outcome in CMT. That said, my general philosophy on this is if it's something extremely safe and not exceedingly expensive and a patient wants to try it with my collaboration, we work together, because I think sometimes when there isn't a treatment, it's really hard to not, want to try things. And so we work together, and I tell them very transparently, this is the data we have, which is usually very limited or none. And if it has any toxicity, then the risk will outweigh the benefit pretty much immediately. Now, for the amino acid question, my research program in part focuses on hereditary sensory autonomic neuropathy, where amino acid synthesis and metabolism are incredibly important. And so it's an area of active investigation. And I think my imagined future for this is we're going to understand these things much better in coming decades, but we have to respect the limitations of what we know now.
Great question. Next hand. Okay. Oh, yay.
Thank you.
Fine. You're showing.
I'm a patient of Dr. Vera Fridman, but I haven't seen you in a while because I've been fine. I have... and I really keep my legs strong. I have a daughter with 1A as well. She's 39. She's expecting her second child in 2 weeks. And her first child is 20 months and hasn't shown he's walking. But my concern is her next child. And so I want to know how early a diagnosis. I was 48 when I was diagnosed. So I was one of those kids that no doctor ever could tell what I had. And one of my 2 children have it. So how early? And she was told there's a possibility of doing a swab test. Is that correct?
There is. So we've changed a lot about how we go about diagnosing CMT, especially when there's a known family history and a known genetic diagnosis within the family. So sorry, neurologists, but we don't have to use the EMGs and nerve conduction studies as our first point of diagnosis anymore, which has made a lot of kids happy. So a lot of our testing can actually be done on a blood sample or on a cheek swab. So we're even saving kids from blood draws right now, which actually helps the parents more than the kids. The kids forget it immediately. The parents are scarred for months. So what we typically recommend, I'm a little biased. We're obviously genetic counselors, so we're all going to say you should come see us first. So we recommend a discussion that your daughter has with a genetic counselor within a neuromuscular team to talk about when's the appropriate time to do genetic testing. And I will tell you it varies from family to family. Some parents would like to know before any onset of symptoms. Some prefer to wait to onset of symptoms. And there's some things around having a genetic diagnosis when we don't know when your symptoms are going to appear. So there are some pros and cons of genetic testing that warrant a more in-depth conversation. So I would connect her with a local genetic counselor if she's here in Colorado. That's us. But if she's out of state, we can help to connect you to your local clinic too that she could go to.
Well, can I add a question? Her preference is to wait until symptoms show. So in young children, what might be some of the early indicators?
Hi, sorry. So pediatric orthopedic surgeon here. Not to give away my fascinating talk that's coming up at 11 o'clock. A lot of these kiddos are toe walking, and they typically will toe walk later than you would usually expect in a toddler. My feeling is that I would establish a diagnosis as soon as possible, and I will touch more on that in my talk.
Okay.
And I'll just add to that. I agree. I also think it's an extremely personal choice. And my sense is that if it causes anxiety during a pregnancy or soon after pregnancy, that it's better, to wait until everyone's comfortable. But that said, as you guys will hear tomorrow, the amount of research momentum in CMT1A really means, I think, to us as a research community that these treatments may come. And so the sooner we know who actually has the disease, it gives that child in the future access potentially to being involved in sort of clinical, not the ultimate trial and then the ultimate trial and the treatment if it is developed and approved. So that's another, being connected to the research arena, I think, can be important even for very young children.
Okay.
But that said, again, there's no treatment today. And so just making sure that, everyone feels comfortable. And congratulations.
Oh, thanks, Vera. And I just want to add, I am actually still the only remaining member of the CMT Denver group that was started like 24 years ago. And I always tell people that the nicest people on the planet are the ones we with CMT and family members. And I really mean that. So thank you so much, all of you.
Thank you. Okay. A question over here, Sarah, right behind you.
Oh.
Hi, I'm Amanda. I have a quick question about cholesterol, high cholesterol, and what to take for it. I've read a lot of forms, and I've been diagnosed with high cholesterol, and they say don't take a statin. So I tried something called Zetia, and I found that my CK levels were elevated, which meant, and hopefully you'll help me with this, my muscles were deteriorating at a rapid rate. So could you help me? I'm going back to the doctor to try to find a good medicine. And I want to know, it could be something that a lot of us go through. Thank you.
Sure. It's a good question. And so to my knowledge, and I'm looking at other clinicians in the room who can counter, but there isn't evidence that statins are harmful in patients with CMT. The elevated CK that you're referring to can occur with statins or with Zetia or with other cholesterol-lowering medications. The tricky thing with CMT and elevated CK is that sometimes in neurogenic nerve disorders, there can be slight elevations in the muscle enzymes because they have a nerve disease. So sometimes it's a matter of knowing where your muscle enzyme sort of was before the treatment and whether it really went up. And any significant notable change, certainly, right? But there can be slight elevations without the insult of the statin. I think that working with a CMT clinic and, having these discussions in conjunction, but there isn't a firm contraindication at all to taking these cholesterol-lowering medications. Once someone has an adverse event with one, like their CK shoots up, that drug class has sometimes been avoided. Does that make sense? And then the other thing to say is it actually is really important to treat cholesterol in CMT because what we know from our diabetes sort of arena is that high cholesterol and high triglycerides in particular actually can drive neuropathy independently of diabetes. And so what we don't want is to have someone have a nerve disease and then add insult to that, right? So it actually is quite important to treat. So I wouldn't avoid treatment for fear of disease progression.
Hello, good morning. I just wanted to ask, if I've not been to a CMTA Center of Excellence before, what would my first visit to see you guys be like?
I'm going to start and talk about our children's clinic a little bit. So we started our clinic in 2020, right in the middle of the pandemic, recognizing that there was a need to focus on the needs of the kids who have CMT because they're a little bit unique from the rest of the neuromuscular community. So we put together this fantastic team of people who have become experts in CMT. And the way we run our clinic, it's a multidisciplinary day where you see all the specialists, neurology, rehab, ortho, PT, OT, and our nurse coordinator as well. Hattie's going to be the face of our clinic. When you come into our clinic, she'll introduce herself to all the patients. You'll get to know her really well. And in the morning, we round on all the patients. We talk about everyone, review all the issues that they've had. If you're a new patient, we'll go over any testing or family history that we know about from the records from your pediatrician. And then when we see the patients, we'll touch base throughout the day, talk about what we're seeing. And at the end of the day, we round on all the patients as well to talk about what we've seen and what the needs are specifically, whether it's bracing, orthotics, surgeries that might be needed. And then we also talk about the mental health and well-being. So if patients have anxiety, school difficulty, we'll refer patients to our neuropsychology team who are well familiar with these patients as well, just to make sure we provide comprehensive care for our patients. So that is generally our clinic.
And she didn't mean to leave out genetic counselors. We offer genetic testing in there too.
There's too many of you people. So yeah, no, I'll just quickly second that. What I tell everyone who comes to our center is because Colorado is interesting because there are a lot of adjacent states where there isn't access to specialized CMT care. So we see patients from Wyoming and, from all over. And so what I tell people is you're not really traveling 8 hours to just see me. It helps to have a clinician who's been trained in CMT. There's no question. And the access to the research. But really, it's a matter of this incredible team. And we're very, very, very fortunate. And so when you come for the first time, I'm the point person for the clinical assessment and talking through the diagnosis if we know it or how we're going to find it out. But then there's an array of people who are, chosen to see you that day based on the needs of the individual patient. And because Michele left out genetic counseling, I'll just emphasize, I can't imagine my work life without our genetic counselors. They are not just there to support sort of the diagnosis, they're scholars. I was just saying this over dinner to someone yesterday. I truly believe in them is like the intellectual future of, CMT and genetic neuropathy. So interfacing with them is a huge part of what we do.
Yes, I absolutely did not mean to leave out our genetic counselors. They're an extremely important part of our clinic. But oftentimes when we see these patients in our clinic, we're not only making diagnoses in the pediatric patients, but sometimes we're also making diagnoses in the rest of the family members. So they're a very essential, important part of our clinic to provide counseling for the rest of the family as well.
And I would say it's nice to have the adult guys on the other side because we do see kiddos and then their dad says, well, my feet look just like that. And we're like, okay, we're going to send you to the adult side. We do have a limit on the age of kids that we see. I would say as an orthopedic surgeon, yes, this multidisciplinary clinic is not as many patients as I usually see in a day because it is so incredibly comprehensive, but it is much better patient care, I believe, truly. The other thing I would say is because we do have such a big catchment area here, we act as a resource for physical therapists, for instance, in other areas. And I think that's an excellent thing that our OT and PT gals here do, where they can send packets, they can coordinate with the physical therapist, and they can act as a resource for them in accomplishing goals back at home. And we just yesterday or day before yesterday did a surgical consultation with a colleague of ours down in New Mexico, just kind of going over goals for the surgery that our patient was going to have down in New Mexico. Do you guys have anything to say? I don't repeat PTs.
And we, as the therapy team, also do a comprehensive battery of assessments that measure specific things that are known to be troubling in CMT. And sometimes I think that can be helpful to look at different the same time points over time. So to see if your efforts doing therapy or doing supplement or a new program are being helpful very systematically. And also our hope is that by collecting data in a systematic way, that when therapeutics do become available, we're very well versed in measuring so we could see if medications or treatments are useful.
Great question.
We have a question from one of our virtual participants.
Hi. So the first question is, if someone's genetic test comes back negative, but they have a nerve conduction test that suggests that they have a type 2, how can they confirm what their CMT type is?
Right. Well, so my experience working in the adult side is that I know we have not discovered all of the genes yet associated with CMT, especially adult onset. So a negative genetic test does not rule out someone doesn't have CMT. It, of course, does make typing a bit harder, and that's kind of when we use those kind of clinical tools like EMG nerve conduction studies to really understand the type. But genetic testing is not the all-being knowing one. We still have a lot to learn in terms of understanding types and the genetic types and subtyping it out further than that.
Excellent. I could just quickly add to that for 1 second, which is, I think one of the really important ways for patients to be involved when they don't have a diagnosis or they have clinical CMT but don't have a genetic diagnosis is the effort out of Miami that you'll hear about more during our research day tomorrow to pool genetic data from patients around the world with undiagnosed, undiscovered genetic neuropathies. And that's how genes get discovered. And you'll hear more about that tomorrow. But the contribution from our patients with undiagnosed CMTs to that effort has been invaluable. And without it, we wouldn't know about, the 30 genes that were discovered in the last decade.
Thank you. Sarah Cater, let's check Zoom one more time. I know we have a lot of hands up here. Any more from Zoom? One more question?
We do. We actually have two, but I'll go with the first one. How much does weight have an effect on the progression of CMT?
Michele.
So this has been looked at, and there are challenges around significant weight gain in CMT. It's not necessarily progression of the CMT itself, but there's a lot of other ways. CMT affects a lot of the way people obviously walk and the musculoskeletal complications of that. And so adding to that obesity creates a lot of challenge, and it creates challenge in young people. And so maybe I'll just...
Well, and the opposite end of the spectrum is true too. So if there's a lot of weight loss and if the kids, we've noticed if they have a significant underweight status, that can affect function as well.
The other difficult thing that I talk to my patients on the adult side a lot is when someone's struggling with weight gain, but they are limited in their mobility and exercise capacity, right? So we have our folks who are in wheelchairs or maybe require a walker, where a lot of exercise modalities are not safe. And this is where having a PT, I can't overemphasize, who really knows CMT and understands progressive neuromuscular disease, because what can be proposed for the situation, this year might look different next year. And so maybe I'll just pass the microphone down for that, as far as, how do we think about patients who need to lose weight to preserve mobility or improve mobility, who can't exercise?
So I'll touch a little bit about this in our talk later, but one of the things that we always want to concern ourselves with is the safety of the exercise. And so working with a physical therapist to provide something that you can kind of get into that fat loss level of activity while safely doing it is very important. When a member of the team we don't have up here is we have nutritionists or registered dietitians, excuse me. I feel Jessica staring at me. And they can be invaluable in that to talk more about the nutrition side of things as far as weight loss goes.
Thank you all. I'm going to move on to a question in the room. You've had your hand up.
Hi. My daughter has CMT1A. She's currently on the youth outing, and these are her doctors. We live down the street. But my question actually would probably be more for the registered dietitian. It was actually about, have you all seen or noticed nutrition deficiencies in people with CMTA or CMT? And do you have any recommendations for nutrition profiles specifically for people with CMT? Do you notice that they're more iron deficient or vitamin D or things like that because of the CMT?
Okay, great.
So we haven't noticed any specific nutritional profiles, meaning that we haven't noticed any specific vitamin deficiencies. In general, in patients who have neuromuscular disorders, we monitor bone health because if you're not quite as active, the bone density tends to be a little bit lower. So we emphasize a well-balanced, healthy diet for all of our patients. Whether some of the teens stick to that or not is a different story.
Yeah, agreed. We haven't seen an associated sort of intrinsic biological deficiency, but I think we watch out carefully for like extreme diets in people who then become B12 deficient. And then that's, a known risk for nerve injury. So that's the last thing we want. So when people come to me and say, I've already tried, the gluten-free diet, and then I tried this some other only carrots for 2 weeks or something, I get really nervous about that, right? Because they're sort of trying, kind of like our amino acid conversation earlier. They're just trying things because they want something to make them feel better. But in the process of doing that, there's the danger of actually exacerbating the neuropathy. And I've seen that enough times now that we have to be really careful. Gastric bypass is a great example. We were just talking about weight. So people get a gastric bypass. And maybe they don't stay quite up to date on their vitamin supplements and they get copper deficient. Well, that's a rare but very real cause of progressive neuropathy. And then we see things that are not reversible on top of their CMT, right? So I think more the cautionary thing is keep a balanced diet.
Yeah. Excellent information. Thank you.
So I'd say from an orthopedic standpoint, talking about, we do see stress fractures on the fifth metatarsal quite frequently in the kiddos because of their cavovarus feet. But they're not a profile like the osteogenesis imperfecta kiddos where they're seeing frequent fractures. I do, in general, recommend a multivitamin with iron and a calcium vitamin D gummy for basically all children in Colorado, mainly because I have a lot of parents who are healthy themselves and not doing dairy and things like that. On the iron side of things, most kids in Colorado need iron because we're at altitude.
Thank you. We have a question right here.
My question is, I am much more severely affected on one side of my body than the other. And I work with two different trainers to, keep up the muscles as much as I can. But when I exercise, I can't feel it on one side of my body as much as the other. And I'm curious, why does it affect one side more than the other? And am I getting as much a result or, work on the left side versus the right, even though I can't feel it?
Can I ask a clarifying question? When you say feel it, is that the soreness after an exercise that you mean? Or is it in the moment, you don't feel the muscle contracting? Both.
Crunches, for example, I can feel it on the right and not on the left. Any kind of exercise on the left versus the right, I can't feel the burn, if you will, right. And I don't feel it as much after either.
There's some evidence to show that there's a crossover effect with exercise. So if you are getting a stimulation on the right side, there is a little bit of something that happens on the left. It's not necessarily the exact same level that you would get of adaptation from that. I think we would also want to look at how you're doing the exercises as well and work closely with your trainer to ensure that they aren't just doing things that are purely a bilateral movement and maybe focusing on dosing the side that you're not feeling as much at a more appropriate level to hopefully get that response. And so you're not so your left side isn't overtaking your right side and vice versa. So things like that, but it would be a little bit more of a individualized.
Yeah. Is there any reason though why anybody is more affected? My left side is more numb, why?
So I can't tell you why, but I can tell you that it's a phenomenon that's well established. So CMT, in the classic CMT 1A scenario, it's sort of symmetric and length dependent, but there's forms of CMT where we see asymmetry. And even in some of the more normally symmetric forms, one side can be more affected, one hand can be weaker. We see that. That's not surprising. Why the nervous system is more vulnerable on one side than the other, I can't say. However, I will say if it's not just one muscle group, if it's like your entire side, then that's when we start to worry a little bit about other things, like is there a cervical, issue or something else that's superimposed onto the CMT. And that brings up a really important point. I think, when you have CMT, I've had so many patients come and say, this thing happened, but my doctor said it was my CMT. And, you hear the story, and as a CMT clinician, you're like, oh, there is no way that has anything to do with your CMT. And you run labs and they actually have developed like a totally different condition. And I think actually, one of our important jobs, because we see so much CMT all the time, is it's important to not get complacent and always be thinking outside the diagnosis, because unfortunately people can have more than one thing. And so there are too many stories like this where someone's becoming, progressively weaker by the month with their CMT1A. And someone says, well, it's your CMT. And it's like, no, they actually have an inflammatory muscle disease, right? It's like they need prednisone. So I think you as the patient also have to be an advocate and say, actually, my CMT has never done this, and because there is a lack of, being informed and educated in a disease that's so rare.
Thank you. That's such relevant information. Also, if you have follow-up questions, you can corner all of these team members later in the hallway. We're going to keep moving with questions.
Yeah, can we use a different word for that?
Gently approach. Do not corner them. Go ahead, Spur.
Hi, I'm Sparda, and I didn't know that a lot of people with CMT were there. When I was born, so I'll quickly go through myself. So when I was born, there was a friend of my mother's, and she said that I don't think she sees with any of her eyes. I was practically blind. I had congenital cataract. So she just spotted that white spot in my eye. And then she said that, okay, so I was operated upon for both of my eyes at the age of 5 months. And that's how I regained vision in one of my eye. That's the right eye, and it's 70%, but the other eye turned out to be a lazy eye. So it doesn't see much. Then my milestones were late, of course, and I didn't put my head up. And then I started walking at the age of, I guess, 4 years. My parents were very supportive, though. I mean, all I am today is really just because of my parents. They were so supportive back there. Otherwise, in India, sometimes parents actually just comment like, "Why are you walking like that? What are you doing?" They were so supportive. They took me to the hospitals. Then, in 2021, just some years back, we got to know about this genetic testing that could be done. I got that done, and the reports were, of course, sent to America, and then we got them back. And one of the doctors, neuro, of course, doctors told me that it was CMT that you have. It's Charcot-Marie-Tooth disease. And I still remember for the 3-4 days, I was just trying to remember what I actually have. Just trying to remember the name of it. Oh, they were T scientists. Okay, so I was just trying to remember that. And I have my reports. I am still not sure what type it is. I've not known that exactly. I don't know. And there were some things. I have multiple problems. I've seen that I didn't have scoliosis otherwise when I was born, but as the time is progressing, I'm developing scoliosis. So there's this spine which is convex on the right side and concave on the left. And like she said, even I'm experiencing something like, weakness on my right side more than my left, and my left is, and I have it in both of my limbs. and even my digestion is affected because of this. So I have like very poor digestion. When I grew after that, doctors told me, okay, you can do some yoga and all. I just went through all the poses. I really do a lot of self-made routine that I have got checked through, with the physiotherapist, that I'm not doing any posture wrong. So I do that. But then there were other things. I developed scleritis in my eyes at some age.
I can say a few things about the story. First of all, thank you for sharing. I think it brings up a couple really important points, and totally happy to talk after about, genetics too. So in your story, like the few things I'm hearing. So first, it's so relieving to hear my parents were so supportive. And I just want to pause that for a second, because growing up in a country where there isn't necessarily access to a CMT Center of Excellence, not knowing the diagnosis, and having a complex disorder that affects like multiple organ systems, your eyes, your digestion, mobility, that's very daunting for families. It's daunting in the US too, but it's a different level, I think, when there's just not as much infrastructure and resources. And so I just really commend them, and it makes me, like, just as a parent, actually really just relieved and happy to hear that. I think that one of the issues the Inherited Neuropathy Consortium, led by Mike Shai, is tackling that is so important, and they're just so effective at everything they do that it makes me feel like we're going to get there quickly, is broadening the reach of the CMT diagnostic access to other parts of the world. And that's been happening over the last few years. There's about to be an added site in Thailand. We have all kinds of PIs, principal investigators, doing research in CMT now in different parts of the world. And the problem with genetic testing is it's been confined to these, countries that have access to that technology and to these kinds of hospital systems. And so I think you're raising something really critical, which is that, it's not that they'd necessarily know your diagnosis in the US when you were a child, but you certainly would have been watched really carefully with CMT in mind. And complex phenotypes, meaning more than neuropathy, are actually not as uncommon as I think they used to be thought of. And, Steve Scher, who's at the University of Pennsylvania, has this like massive spreadsheet of all the different complex phenotypes in CMT, and it's enormous. Every time I look at it, I get sort of overwhelmed. But, these complexities also help us to find genes, because if we can say early cataracts, gastrointestinal involvement, A, B, C, D, Stefan Zuckner might in his enormous database have like 5 or 6 patients like that. And then it allows to narrow the diagnostic search. So it's actually, I think, very hopeful that we'll find genes for you and for others. Okay. Thank you.
Yeah. Thank you.
Thank you, Sparta. We're going to go here to Fran for a quick question.
Yes. Hi. Good morning. I'm Fran Roberts, and I'm from Phoenix, which, by the way, is the 5th largest city in the United States. So I have noticed a dearth of centers of excellence this side of the Mississippi. So I would be talking to you later about that. How do you go about forming a center of excellence? That's my editorial comment. I am a registered nurse and a nurse practitioner, so I'm curious about the role of the nurses in the team.
Yeah, thank you. Great question. So as a nurse practitioner on the team, I focus on a lot of the rehabilitation medicine piece with my counterpart, Dr. Apcon, who's not here today. So focusing on bracing, focusing on equipment needs, and also therapies. On top of that, I also worked very closely with Hattie with some of the care coordination that happens, and I'll let Hattie speak a little bit more to that. And also just kind of being able to connect with families and provide further access to care.
Yeah, so as the nursing coordinator in clinic, I do kind of just the regular nursing things. We have a very large clinic, so it's very busy, kind of making sure everyone gets where they need to go. I also help with a lot of education or wound care, things that come up patient to patient, especially with new patients. I get everyone connected with the CMTA. And one of the biggest things that I do in clinic for specifically the CMT patients is connecting with schools. I can't think of one single patient who hasn't had issues at school.
There's a total lack of education among even just school nurses. They've never heard of it. Most of them are so appreciative and happy to learn about it. We use the CMTA school guide, and I individualize it to each patient, send it with the families, and then at their request, if needed, connect with the schools to help with the development of 504s and IEPs. And then in between clinics, help with navigating questions, concerns from parents and families. And then a big piece of what we're trying to improve is our coordination around surgeries. So Dr. Murphy-Zane will connect with other orthopedic surgeons for hips and feet and spine. And then Kelly and I work together to meet with those families afterwards as best as we can to make sure that they're getting connected with therapies, they have the home equipment they need, that they're back in school. So I would say the biggest portion of my job is outside of clinic. And then, as I mentioned at the beginning, if we have families that have moved to the area or they have referrals, maybe they've seen their pediatrician, maybe they've seen orthopedics and they've been referred. I work with our scheduler and Melissa to coordinate all of our referrals, make sure people get where they need to go to be seen as quickly as possible. So a lot of it is just trying to keep all the pieces together so that the brilliant minds can do what they need to do and the families have follow through on the back end.
We love nurses. Gentry, there is a person, the gentleman in the white blazer. We're going to go over here. We have a lot of questions, so we're just going to do our very best to get them answered. This session does end at 10. My watch is telling me to do an EKG. It's fine. I'm fine. It's fine. Go ahead.
Thank you very much. My name is Javier Peña. I'm coming from Ecuador for the summit. This is my first summit. I'm delighted to be here. Thank you very much. My question is regarding the exercise. Being exercise, one of the ways, a few ways known to slow down the progression of symptoms. Is there any limit that the exercise must go or must not surpass frequency, strength? Because I heard there are limits and perhaps too much exercise is not too good, something like that. I'd like to know about that.
We are going to cover that pretty in depth in the PTOT portion of the talk. Sorry about that. The conference today, and afterwards, I'm happy to go over any sort of individualized questions that you might have about that. But we'll talk a bit more about the guidelines in a bit. Yeah.
Awesome. Yeah, we'll do that. Session is immediately following. So I'm going to float over here to some hands that I've seen up.
I am curious. I actually work as a consultant in the health and benefits space. I'm actually curious what the most common accommodations are that your team assists employees in the workplace to get in order to help them live with their disease. And I know this is probably an unfair question since everyone varies so drastically, but I also wonder if there's things that those of us here haven't thought about to ask for from our employers that might help us be more comfortable and more efficient at work.
So from an occupational therapy standpoint, and then maybe you can talk maybe about more the physical components to whatever one's employment might be. We would want to be understanding what your work setup is like. So we would be doing some ergonomic evaluations. Am I on the right page of what you're asking? So frequently I will ask individuals, if possible, to take pictures, take videos, so that I can see how one is working and how maybe their position is, and then how can we begin to add in some appropriate ergonomics to allow you to work more efficiently and decrease any type of compensatory movement patterns, especially as we work through the day and we begin to fatigue. As you can imagine, probably one of the most frustrating components is the keyboarding, and what adaptations, what may we look at in that scenario? Is there an opportunity to do some components of your work in any type of dictation form? But then again, it goes back to ergonomics. There are some nice, relatively inexpensive You'll see it in the slide. They're called tabletop mobile arm supports. So I think about the hands and the intrinsics and how they begin to become weak. And so we're not very efficient at our work if we're talking about keyboarding. And so there are things that can be attached to your workspace where your arms can rest and kind of, for lack of a better word, like a trough, and it moves 360 degrees. So then my shoulders are relaxed, my elbows are at 90, and my hands can kind of move over the mouse or over the keyboard a little bit more efficiently. So I'm thinking about how can I help someone work for a longer duration of time and decreasing compensatory patterns.
Thank you.
Is that appropriate?
I just would like to add in one additional thing. Also just thinking about taking breaks versus movement. So a lot of our roles are either very much seated or very active. And I think there's a nice balance that needs to be achieved between the two in order to be efficient and feel like you can do all the things in your day that you need to. So that's just another thing to think about.
I also want to speak to the pediatric side. So while it's not in the workplace, but it is in the school, that we provide a lot of accommodations for our kids. Being able to type instead of write, not being graded on handwriting, not being graded in PE, allowing for breaks as needed. So things like that to think through as well from the pediatric side is really important.
Thank you. I want to go to Sarah Cater. Do we have any Zoom questions?
So we have a question about how common it can be for a person who has CMT to also have dysautonomia.
That's a great question, actually. So the straightforward answer is it's not common to have severe dysautonomia with the common forms of CMT. Does that make sense? So, I guess I'm asking someone who can't respond. So most of our common forms of CMT, let's say CMT1A, we don't see a lot of dysautonomic symptoms in those patients. There may be more subtle involvement of the autonomic nervous system that doesn't meet the kind of clinical symptomatic threshold, but it's not a common part of the disease. That said, there are rare forms, particularly like the hereditary sensory autonomic forms, some of which have profound autonomic dysfunction. Okay, so those are very striking, and you know that when you see it. But what I will say is I think that all of us clinicians around the country who see a lot of potentially genetic neuropathies have seen a lot of dysautonomia. And like with all diseases, my hunch is that a good bit of that is probably genetic. It's just that we don't know that yet. And I think it's an evolving realm where we may find that there's a gene that's thus far unknown that accounts for more of the dysautonomia than these really, really rare conditions where we know it exists and there's a gene that's already known.
And then we have one more question. Is CMT a diagnosis that qualifies for Social Security disability? Maybe not the best person to answer this, but as far as I know, in terms of the pediatric world, many of our children do qualify for some different state benefits, Medicaid waivers, and Social Security. I encourage you to work with your provider to write up any letters that fit your specific needs to support your application for Social Security. But the resounding answer from the crowd is that yes, it does. Seek out your benefits.
Yeah, a lot of nods. Yeah, in my adult population, we definitely formulate disability plans for our patients who have physical limitations, get exhausted. It's also a really important conversation that I have up front with my younger patients. And so as much as it's an uncomfortable conversation, I think it's a really important one. In my mind, it's up there with asking a 19-year-old boy if he wants to have children and whether he's using protection and, things that they may not want to talk about, but actually is really important, right? And so this is another one of these things where, I have a patient who's 20 and he's doing great and he wants to, I don't know, be a firefighter or something, right? And so as much as maybe they don't want to address this, you have to say, okay, how long do you think if this progresses, that will be a feasible plan? Do we want to do that in the short term and have a backup plan, right? And I say this to the point of you can qualify for disability for certain jobs, but what I love to see is for my younger patients to then pivot to a different profession that they can continue to work in full time and really, capitalize on their talent in some other way, right? So those are conversations to start early, I think.
Thank you. So I hate to be the bad police that says this is our last question for this session, but I will remind you that this amazing team is going to be around all morning. We have breaks coming up. We have an hour long for lunch. So please find them, seek them out, ask your question. But Deb here has won the award for the last question, and she promises it's short.
I'm 68 years old, and I received my diagnosis on May 27th of this year. So this is really new, really fresh, maybe a little emotional for me. So my question, I guess my life mantra has always been when something new has been thrown at me or at any of my family members, I jump in with both feet. My mission is to learn as much as I can, as fast as I can, and do what I can to help. So my question to this team, you guys did a great job of presenting. Sorry.
Don't be sorry.
And I also feel very fortunate because I happen to have a home in Parker, Colorado, and this team is right at my fingertips. So my question, you've done a great job of presenting all the services that you offer. I want to engage with you. What's my step one to make that happen?
So probably just come see us is the step one. But I want to just say one thing about what you just said, which is that I love the family mantra. And I think a lot of us in the room can relate, especially maybe the slightly type A among us, where I belong in that group, as you can imagine, right? Like with my own kids or, okay, we're going to start doing things, right? And I just want to introduce like a moment of hesitation. Sometimes before starting to do a lot of things, you have to kind of sit with the news, right? And the uncertainty of what it brings and kind of give yourself a lot of grace. I think that sometimes the proactive in us, kind of displaces just the ability to grieve through something. And so these two kind of work together. And we talk about that a ton in clinic of just, I sit down with my patients and I say, this is like real, right? So you're not going to be able to do this thing that you really wanted to do. Like, let's sort of together appreciate how much that sucks, right? And then we can maybe think about what to do after that, And so I think that's a really important moment for all of us and whatever we're facing at a given time. But if you were to come to see us, that would connect you to this team and also other resources. And I want to say this before we close. So one of the things, so first of all, Ron is incredible and has been doing this work for a long time. And he is, you could stand for a second. Yeah. I could tell you I had a little bit of hesitation moving here from Boston. I didn't know anything about Denver. I'd never been here. I didn't know anything about the hospital, and I didn't know anything about the CMT world here. And so, it was an abrupt move, and it was a little daunting. I met Ron pretty early on, and he is just one of the most understated pioneers for CMT I've ever met. And working with him has just been so incredibly heartening. And so he and I recently have started to work on broadening the access to therapy and services around the state because we have so many patients who can't easily, make it into our clinic and to see our therapist regularly at UCH. And so if you know of anyone in your region in Colorado who you love, like a PT or OT, massage therapist, kind of anybody at all who has really understood CMT, please let us know because we are compiling kind of a massive list for people who can't easily access care. So that's just my last little request.
That is wonderful. Can we have an enormous round of applause for this amazing team?